So next we have Brian Hansen. Brian Hansen is a community-based research consultant in Calgary, where he's worked with a number of stakeholders locally and provincially to coordinate research projects related to MSM health and wellness, HIV prevention, and harm reduction. He's previously worked as the Gay Men's Health Promotion Specialist at the Calgary Sexual Health Centre. Just press next. And currently oversees the Health Equity Research Portfolio for the Alberta Cancer Prevention Legacy Fund within Alberta Health Services. Please welcome Brian Hansen.
Awesome, thank you. So that's what you're doing. I'm on TV? Good, good. My hair and makeup person didn't show up this morning, so this is the face that you're going to get for all of this. Thanks for the introduction. I am Brian, and I am presenting on part of a team, and I am presenting on part of a broader group of individuals that really brought their insights together to inform this work. Namely, I'll just acknowledge Brent Oliver, myself, Floyd, who's here, and Spencer, who's here. There you are, Spencer, who've been directly involved in preparing this work that I'm going to show to you today. So I'm glad that I'm following up on Cari, because Cari really touched on a lot of different pieces that I think really stitched through. So whoever put the agenda together the way that they did,
it was a lottery, actually.
Well done. Oh, it worked out perfectly. It worked out perfectly. Because I think that a lot of what Cari mentioned are themes that you'll see come through in the work that we've done. Obviously, HIV still a big thing for MSM in Alberta. Still something that needs to be tackled. The government of Alberta has acknowledged that we're seeing a resurgence of this, and I think Cari presented a lot of great data that demonstrates this. So a little bit around the Alberta context. It's a busy slide, my apologies. We've got a lot of interesting things happening in Alberta right now. So we're seeing an increase in health education targeted for MSM youth. So for example, Totally Outright, which I know is sort of a fan favorite of the Gay Men's Health Summit, is now being delivered in Calgary's 2 major cities, and that's a relatively recent evolution. We're seeing an increase in work to address stigma. So Cari mentioned work that's a partnership between the Canadian Public Health Association and Calgary Sexual Health Centre that's focusing on stigma reduction training for professionals. There's work that's going on. I know Patricia Miller, I think, was presenting yesterday along with Lana Wells around intimate partner violence amongst MSM, and that work's being done in collaboration with the Southern Alberta Clinic. And we're seeing great examples of some community-based research. Cari, again, he's so good, mentioned some of them. So the Edmonton Men's Health Collective has been doing some great work, and the Calgary Men's Wellness Initiative, of which I was a part of, has also been doing community-based research. And then obviously the Alberta Health STVBI strategy, which I don't think Cari sold it enough, is a massive endeavor in collaboration. Like, it's huge, huge. It's like the whole bloody province, and AHS has led it in a great way, and AHS is an organization of 108,000 people, so it's a pretty big undertaking. She's been very, very busy. We've got some great recent collaborative work that's going on, so we're involved in several large national projects, not all of which are listed here. And really, we've got some great expertise and some mobilization and some momentum in Alberta, but what we found is that we actually are really lacking in terms of collaborative work. A lot of the work that is happening is very isolated, and I loved Cari's diagram again of all of the arrows going in different directions, because that's really the case that it may be. We were just sitting here all of like maybe 20 minutes ago talking about doing a scoping review, and Cari says, well, they're doing a service mapping, they're doing a service mapping, they want to do service mapping. It's like, okay, we all want to do service mapping, none of us are talking to each other. This seems a little bit disjointed. So one of the things that we wanted to do with this work is bring people together and say, what do we need to be looking at a provincial level around mobilizing community-based research for HIV prevention? So the questions were really, what community-based research is needed, and how do we generate localized knowledge to address health inequities, inform our program planning and development, and our future service planning. And so to do this, we hosted a 2-day consultation back in January. I should say that this work built off of work that was done by the Calgary Men's Wellness Initiative earlier, where we talked to MSM. We did Calgary's largest survey of MSM health and wellness, and really got the perspective of individuals. And so with this work, we've tried to focus on getting the perspective of the people that support those individuals. I should also now we'll talk about that later. So in terms of how we did this, we hosted a couple of focus groups and frantically jotted down field notes throughout 2 days of consultations. My fingers were pretty sore after all of that. But really, we had 2 days where we got everybody together in a couple of rooms, talked through a whole bunch of different issues and discussions, and recorded all of it. Plumped it into NVivo and did some thematic analysis on it to come out with some of the findings that I'll talk about today. In terms of who was in attendance, well, we aimed on having stakeholders from the public health sector, academic institutions, HIV/AIDS serving organizations, other community-based organizations and nonprofits, as well as MSM community members. I will say we tried very hard to ensure that we had provincial representation, but that's easier said than done. And I think that this is quite telling of the state of work in Alberta, and I'm curious to know if it's similar in other provinces. We wanted to ensure that we had smaller urban centers represented, but the fact of the matter is that there's not a lot of people that are doing this work in smaller urban centers. It's really easy to get the team from Calgary together and get the team from Edmonton together, and we had some success getting people from Alberta's northern communities together. But when you want to talk about what's happening in rural communities or what's happening on reserve, that's a lot more challenging. There's people not doing that work, and I think that that is in and of itself a really huge gap. So in terms of our findings, the overarching theme was that people want research that is actionable and that can filter up into the frontline work that is occurring. We're not necessarily, or at least the individuals that were in attendance, interested in peer-reviewed publications. People want stuff that they can put into action and do something with. So that point was well taken. Several themes emerged, including intersectionality and inclusion, sexual health and primary care, social isolation, program science, sexual health literacy, and enhanced surveillance data. And this probably isn't surprising. Certainly coming to this conference and attending this before, these are pretty common themes. They come up all of the time. I mean, is anybody shocked to hear that people are interested in how sexual health and primary care fits together? No, not really. We're not telling you anything that you haven't heard before. But I think that that's quite potent as well. The fact that these themes keep coming up says that we still have so much work to do. We haven't quite got there yet. The last theme was around enhanced surveillance data. And I'm not really going to touch on this because we kind of recognize that we're actually not the people to be dealing with enhanced surveillance data. In Alberta, surveillance data is really controlled by Alberta Health, and there's varying degrees of access in terms of who has it. Personally, I'm a surveillance research associate. I would love to see more of our data liberated back to people so that they can use it. A lot of the people that attended our consultation said that they would benefit from having timely access to data, but that's just kind of not the reality for us right now. Those beautiful slides that Cari presented, I couldn't actually pull them off if I wanted to. So there's a difference in access to data, and we'd like to see that change, but that's all I'm going to say about it. Hill to die on? Maybe. Soapbox, bring it out. In terms of the first theme around intersectionality and inclusion, we had a great quote from one of the participants who said, "I think you need to ensure that whatever communities are involved, they're involved at all tiers." And this sort of stems into our first point, that we need to focus on, we don't just need to include less traditionally represented populations at MSM. So it's not about, let's do this research and then let's make sure that we have this voice and this voice and this voice and this voice. It's about, let's see what this voice has to say. Certainly in a lot of work that we've been doing, and certainly I've been seeing in a lot of the work that's been presented today, we do a great job of capturing cis, gay, white men between the ages of 25 and 45 who make, a 6-figure income. We got it. We know what they have to say. We've been hearing it forever. We need to do better. People were particularly interested in addressing how MSM in rural and northern communities are overlooked by our work. And again, this comes back to access in terms of population access in a lot of ways. And people were really interested in the newcomer, immigrant, and refugee experience. What are their experiences in terms of accessing services? What are the gaps there? And what are their unique challenges? Because they are underrepresented both in terms of our research, but also in terms of clients who are accessing services, and likely overrepresented in a lot of the negative health outcomes that we see. And to that, we need to better understand the disproportionate burden of new HIV infections and, quite frankly, other health and wellness impacts that comes along with having reduced access. So sexual health and primary care. I won't read this particularly long quote, but you're welcome to if you like. The gist of it is it always comes back to the frontline service provider. Why do they still not get it? What is that challenge? And look at how that's actually impacting me. So we need to explore more primary care's role with MSMs, how their interactions are operating, and what some of those challenges are. The work that the Calgary Men's Wellness Initiative did previously looked at some of the barriers that MSM face in accessing healthcare services, and some of that really spoke to ideas around stigma and cultural competency. And that certainly has played out in terms of how the service providers are seeing this as well. So from the MSM's perspective, there's barriers to accessing health, and then from the service provider's perspective, they're saying, hey, there's barriers to accessing us. So I think that that's quite telling. So to that effect, what role does stigma play in separating or specializing, depending on how you want to look at it, sexual health care from primary care experiences? The sentiment is that we've niched out sexual health from our health. So sexual health is a completely different entity unto itself. And the way that our systems and services are organized really speaks to that. So for example, we have centralized STI testing clinics, but we really don't, well, I mean, I shouldn't say we don't, but a lot of individuals are not accessing sexual health services through their primary care providers. So there's a lot of opportunity for improvement there. So we're curious about what is the roadmap to reintegrating sexual health promotion into primary care settings. Now, I'll just pause and say, I've worked on a lot of different projects that have touched on a lot of different things, whether it's domestic violence prevention, HIV prevention, I'm working on cancer prevention now, and every single project I've ever worked on always comes up and says we need to be knocking at the doors of the doctors and of the medical schools and saying, dear doctors and dear med students, we need you to fix this. We need you to take more training. We need you to learn differently. We need you to learn better. We need you to provide better services. And I don't know that that's necessarily realistic or practical, because I have to think that if my domestic violence prevention and my HIV prevention and my cancer prevention work is all sitting there knocking at the doors of the doctors, that every other person who wants to prevent any sort of health, poor health outcome is also knocking at the doors of the doctors and the med schools. So yes, we need to change that. I don't know how we do it, but also let's not dwell on it and focus on it because everybody else is doing it too. And them doctors, them med students, they're busy. So another one that came up really strongly was social isolation. I love this quote on the side there. We were all expecting guys to want health services, and it turns out that they want friends. When we did the work for the Calgary Men's Wellness Initiative, we set out and we're like, what are the health services that these guys need? We gotta figure it out. What are they looking for? Do they want mental health services? Do they want help with substance abuse? Do they want more STI testing? Where do they want it? And the number one thing that they came back with was, I want social opportunities that don't involve sports. And the number two thing that they came back with was, I want social opportunities that involve sports. And we're sitting there being like, oh shit, okay. Here we are being like, let's build them a clinic, let's get them psychologists, and they're like, let me just get some friends. So social isolation is a strong theme that came out from the service providers and people who support them as well. And the question is social isolation a cause of poor health, or is social isolation an outcome of poor health? And the reality is it's a trick question, it's both. And so we need to think of it that way and address it that way. We're curious as to what is the impact that socialization is having on MSM's health and wellness in Alberta. And then I love this, the strategies that MSM use to actually address socialization and its effects. We had a couple of people who participated in the consultation who, and this was sort of like the penny has dropped moment for me, who really hit home the point that we need to be focusing on resiliency. MSM are a resilient population, and there is a lot of strength there. I worked for a woman a number of years ago, Lana Wells, and she taught me something, and I will cling to this till the day I die, that we need to focus on momentum and readiness. You can waste energy, you can waste time, and you can waste money trying to build that. Instead, find the people who are already going in the direction that you want to go in and move with them. MSM have momentum, they have readiness, they're dealing with these issues. We need to tap into that and build on that and utilize that to support them to the best of our abilities. And so a lot of work that focuses on this area really focuses on people's deficits. What are the problems that they have? Perhaps we need to flip that and focus on their strengths. And I know that I'm saying this probably to an audience of people, the converted, but I think that that's something that we need to remind ourselves time and time again. So other things came up around program science, and this is sort of the issue around service mapping. The reality is that we don't actually know what's going on in Alberta. I mean, I know what some people are doing, and I might know what other people are doing, and I'm pretty plugged in. Like, as far as I'm not your average Albertan, I'm pretty engaged with this stuff, and I don't know what's going on. I don't know what's happening in Medicine Hat or Lethbridge. I don't know what's happening in Edmonton. Thank you. We don't know, and so we actually need to figure it out. We need work that's going to support evidence-based interventions in Alberta's communities. A lot of the research around evidence-based interventions comes out of Montreal, comes out of Toronto, comes out of Vancouver. And I hate to be the guy that kind of shits on all of that because it's really important work. But the reality is that Vancouver is not Calgary, Vancouver is not Edmonton, and Vancouver certainly is not Lethbridge, Alberta. And so a lot of what we learn doesn't necessarily translate. I think that you made that point really well around rural communities. So we need some more localized evidence. And essentially, we need to better understand what is going into interventions, what evidence is informing them, but what evidence is also coming out of them. So what's working really well? A lot of research, and you're probably all familiar with this, likes to focus on building the shiny new toy. Let's get some funding and let's build a new program. We got a lot of programs. There's programs happening everywhere. There's a new program popping up every day. Every little researcher here is applying for funding to develop a new program and generate evidence from it. We got some good ones. Let's focus on scaling them up. I think Totally Outright is a great example of how that started as a program, gathered some evidence around it, and it sort of spread. And we're not trying to constantly reinvent Totally Outright. Like, let's stick with something that's good and utilize that. But right now, we don't actually know what is the goodness that we need to scale. So we got to figure that out. And then last one here is around sexual health literacy. So the quote is, if we know how MSM learn about sexual health, then we can have our programs target those learning strategies. And again, this is about momentum and it's about readiness. How are they learning what they're learning and how do we work with them? So we need to understand better how MSM in Alberta learn about sexual health and HIV prevention. That woman I mentioned earlier, Lana Wells, she taught me one other thing, and I'll teach it to you too because I thought it was great. And she said the best interventions happen at kitchen tables, and I really, truly believe this. We learn more talking to our friends over beers than we learn from sitting and listening to healthcare providers or sitting in sessions like this. And so how do we utilize that and build on that momentum? How are MSM learning about things, and how do we invite ourselves to sit at those kitchen tables? Oh, hi. In relation to this, what do MSM know about biomedical prevention? So Cari presented some great information from the AMHC as well as the Calgary Men's Wellness Initiative. What do guys know? Where are they learning it from? And how do we get that information out to them? So really, this leads to a bit around equity. Who gets to have sexual health literacy? Who doesn't? And is it equally distributed amongst populations within Alberta? The answer is it's not. We already know. So in closing, it's a pretty busy slide. A lot of this stuff aligns with things that we already know around identities and buzzwords like syndemics. That came up a lot, particularly around mental health and substance abuse. There's definitely a consensus within Alberta that we need to be considering HIV prevention within a broader context of health and wellness. And I don't think that that will be surprising to anybody here. As I mentioned, the concept of resilience came up quite a bit, and there's the sentiment that we need to focus on that, which I think is great and powerful. And that sort of extending from that, we need to take strengths-based approaches. So let's stop focusing on deficits, but let's start focusing more on what are guys doing right, and let's work to enhance those. Again, reiteration of syndemics. I guess I needed to put that on there twice because it is such a buzzword and we do like to talk about it a little bit. I could throw a citation in there too, make me look really profesh. And then, while there's lots of research topics that emerged, the thing that people want most of all is something that's actionable. They want something that they can actually use and do stuff with, and they want it to be localized. I mean, I do believe that there's a lot of great work that are coming out of locations, but we do need to know what's happening in Alberta from the perspective of Albertans to an extent. And so a lot of this has really alluded to the fact that we need more collaborative work. We need to work broader, we need to work bigger, and we need to work together. I'll just acknowledge this work was supported by CIHR, and I thank all of the individuals that participated within the consultations, but also in getting this work together. Jody, I see you yawning over there. Am I putting you to sleep? Yeah, I know. I'm done though, so it's your turn.
Thank you, Brian.